So thanks a lot, first of all, for the opportunity, and thanks a lot for being here today. So I understand I have an hour, so you should feel free to interrupt me whenever you want. The good news is that I don't have to try to show you 39 slides. So that really includes all the backup slides, and most of them are backup slides. So once we reach slide 6 or 7, I think you're gonna know what the punchline of the paper is, and then we're just going to fill in a few gaps here and there. As you can see, this is a joint project with a bunch of other people. I in the project started talking about this back in 2005. Brian is a doctor at the Stanford School of Medicine. Dan and Lakshmi are the two research associates who really spent a huge amount of time in the field working with us to take care of all the logistics in the field. Joanne Young was a Stanford PhD candidate back then. Now she's at the Rand Corporation. So the title tells already what this is going to be a bit about: microloans, insecticide-treated bednets, and malaria, evidence from a randomized controlled trial in Orissa, India. I'm usually going to talk about ITNs. ITNs is just a shortcut for insecticide-treated net. So just a few words of motivation, probably not necessary for this crowd. We know what malaria is, and we know it's very bad for you, and we know it can kill. So just a super short summary. Malaria is caused by Plasmodium. This is a protozoan. Several species of Plasmodium, 4 in particular, affect humans. And PF, the Plasmodium falciparum, is the one that causes the vast majority of deaths worldwide. This is something which is transmitted by particular species, particular kind of mosquitoes, particular genus of mosquitoes, Anopheles mosquitoes. There are almost 500 different species, about 30-40 of them that transmit the disease to humans. The global burden is huge. We know that about 1/3 of the human population lives in places where you are at risk of contracting malaria. As you can imagine, for any global estimate, these estimates have extremely large confidence intervals, but you often hear numbers like these: 660 million of cases of falciparum alone, and of these 80 million cases in India. You may have heard recently, actually, of an article according to which the death burden of malaria in India had been severely underestimated by the WHO. I think there is still no consensus about who's right, but anyway, in terms of cases of malaria, India certainly is, together with Africa, where things are even worse, a continent where malaria really is a very big problem. We know that, of course, you can die of malaria, especially very young kids under the age of 5, and pregnant women can die quite easily of malaria if you don't get treatment quickly enough. Very young kids, for very young kids, this is true because you do develop a certain degree of immunity if you are exposed to the disease for a long period of time, but kids obviously have not developed that kind of semi-immunity yet, so they're much more likely to die. Unfortunately, even once you are semi-immune, you can lose the semi-immunity very quickly, so it's still a problem even for adults, and especially in places actually where malaria comes and goes. But anyway, something else that we know is that even if you don't die of malaria, and most people don't die of malaria, the disease itself can be not only extremely uncomfortable because of the terrible fevers that can hit you, but there are also long-term consequences for health along several dimensions, like severe anemia. There are pregnancy complications, kidney failure, and many other things that can happen. The economists have been interested in the causal link that goes from malaria to economic development for a long time. There is now recently a growing number of papers that really nail down the causal association between the two. Several studies that show, for instance, that after the eradication of malaria in certain areas, economic development really kicked off. So there's no doubt that malaria is not only bad because of the health consequences, but also for the economic consequences of it. Unfortunately, as I'm sure you all know, there is currently no vaccine for malaria, and the only thing that we can do about it, well, you just avoid places where there is malaria. If you have to go there or you live there, there is vector control, prophylaxis, and treatment. So malaria can be treated usually relatively easily if you have access quickly enough to the appropriate drugs. In terms of prophylaxis and vector control, there are several things you can do. One of the foremost interventions that a lot of people talk about nowadays is a provision of insecticide-treated nets. These are nets that you sleep underneath in places where there are lots of mosquitoes around. They protect you because they provide a mechanical barrier between yourself and the mosquitoes. And if the net is treated, not only that, but a mosquito that touches the net is also going to die. So not only you can protect yourself, but you can also reduce the number of mosquitoes around. And this actually turns out to be something very important, and we believe this is also going to be extremely crucial for the interpretation of our results. I'm going to tell you later what they are. Besides ITNs, something else which is often used to control the number of mosquitoes is residual spraying. So you spray indoors or outdoors walls with chemicals. And of course, there are larger things that require huge amounts of resources, like, for instance, getting rid of swamps or water management, land management kind of things. And those have been extremely important in the past in places where really malaria has been eradicated. So something that I should point out is the fact that despite I can tell you immediately that the punchline of this paper is going to be that in our context, we did distribute a large number of ITNs, but we did not find health benefits. Of course, I'm going to tell you much more about that, but something important to keep in mind is that we don't think that our results negate in any way a very large and great literature that exists out there, which has shown quite convincingly that in areas where a very large fraction of the population has treated nets, and when these nets are used regularly, ITNs really can be very effective at reducing the malaria burden. And by reducing the malaria burden, what I mean is, well, you can mean different things, but we are talking about reduction in prevalence, reduction in incidence, reduction in severe cases of malaria, improvements in different health indicators like hemoglobin levels and anemia. This is important. Hemoglobin levels are important because one of the many bad things that malaria does to you is it destroys red blood cells. So typically people with malaria also have very low hemoglobin levels and potentially very severe anemia. Something else which is extremely important is that in the few studies that really took seriously also the number of changes in the mosquito population, so studies where not only they were looking at how people reacted, but also how mosquitoes reacted in a sense. So these studies show that there were very important community effects. This is what we economists call externalities. But what this means is that if a lot of people are using Bednets and these are treated, even if you don't use a net, you are going to be protected to some extent yourself. There are actually studies that suggest that this second pathway, the community effect pathway, is at least as important as the direct protective power that the net gives you, simply because you sleep underneath. So just one second. So it's very important. This is very important. So in many of these studies, people have observed a large decline in the number of mosquitoes and the parasite load inside these mosquitoes. Yeah.
I mean, this might be trivial, but I'm just trying to think of a situation where, if there's a group of people who start using Bednets and I'm the only one who doesn't use a Bednet, would that mean I'm more likely to get bit by all the mosquitoes?
So that's a very good question. But the answer is that what we know about treated nets is that the answer is no. And the reason is that the nets are treated, so the mosquitoes are going to try to bite people, they're going to die in the process, and then you're going to be protected.
I see.
If instead these bed nets are non-treated, then the link is more complicated. Although, even in that case, it's still you can build quite complicated epidemiological models, because it is true that maybe mosquitoes are not going to bite me and they're going to come after you, but you're also reducing the number of people that are potential that are going to have malaria potentially. So the actual result really depends on a lot of different parameters. But the consensus is that the ITNs really protect you through the insecticide, which is many of the studies cited here in this great review, Langler 2004, actually compare the protective power of ITNs versus untreated nets. So these are not simply ITNs versus nothing. There are several where you really look at the impact of all the retreatment.
And as we look at the results coming up, do the ITNs, are they more effective, right, as they are distributed, and does the insecticide sort of wash out over time, or is it?
So that's a good question, and let me. Well, actually, I can talk about this now. So in our case, the answer is yes. But the reason is that when I talk about ITNs within our project, what we used was a standard bed nets. These are nets which are made with a very good quality, made in polyester. But these are nets that you need to treat with insecticide approximately every 6 months, given the concentration of chemical that we are using. Now, these are not what the WHO is recommending nowadays. So now there are many programs around the world where the recommendation is that you should use not these nets, but those so-called LLINs. These are long-lasting insecticide nets. And these are nets where the chemical is actually woven into the fabric, so you do not need to retreat them. In our case, your answer to your question is absolutely yes. And you're going to see later, I'm not going to talk too much about that, but you're going to see later a bit why we chose to work with these standard nets. Just to say a couple of things quickly, I mean, one thing was that long-lasting nets, although they have been recommended by the WHO, are really not that widely available yet. They are becoming more widely available, but in many poor areas in the world, what you find in local markets is standard nets, not the long-lasting ones. And the other thing is that I'm going to show you that we really cared about the retreatment itself. It's actually part of what we were worrying about. So that was an important component for us. Okay. What is the big question that we are going to try to address here? So the literature, the econ public health literature that we try to talk to here is the one that looks at public health interventions, and this is a literature whose main question is: so should we provide these health protecting technologies for free or through or should there be cost sharing? Now. Public provision is often advocated by many. The WHO is often, certainly for the case of ITNs, suggests, strongly emphasizes the fact that we should give these nets for free. Jeff Sachs has been insisting on that a lot. Two very simple reasons for this is one I already told you, which is the fact that there are very important community effects. So this is the kind of situation where in economics we say there is room for subsidization because when you decide whether to buy a net, you only look at your cost and your benefit without actually really taking into account the fact that if you use a net regularly, you're also protecting others. So this is kind of prototypical example where a subsidy can be of use. Another issue is the fact that we know from many different studies, several from economics, but also outside of it, that in poor areas you increase prices even by a little, and often demand goes down really exponentially. So there are a few examples here. For instance, this work on the warming drugs by Kremer and Miguel, 2007. And these warming drugs were actually much cheaper than the ITNs that we're going to talk about. And the ITNs I'm going to talk about are not outrageously expensive, but as I'm going to show you, they're also not so cheap. So you have to think hard about whether you want to buy or not. Here we are talking about something which really was only a few cents, and what they found here was that the introduction of 20% copay led to a decrease in uptake of these drugs from a decline from 75% to 19%. When we look at water disinfectant, for instance, another two studies in Africa, Zambia and Kenya, Ashraf, Berry, and Shapiro find an elasticity of minus 0.6, which is very high. This pretty much means that you increase price by 10% and demand goes down by about 6%. So very sharp decline in demand. This is another paper where when they were offering this water disinfectant with a 50% subsidy, there was only a 10% uptake. So even with very large subsidies, often demand remains very low. This is actually much closer to what we do, although we are still talking about Africa, about Kenya specifically. This is Cohen and Dupa, and what they found is that when you go from free provision to a 10% copayment, so again, very small copayment, demand dropped from pretty much 100% to about 40%. So again, very, very steep demand curve. On the other hand, it's very easy to say we should give stuff free to poor people. there are reasons why this may not be feasible. Sometimes simply that we don't have enough money. I mean, when we talk about free stuff, somebody actually pays for it. So it's not maybe the beneficiary, but somebody pays. So it's not obvious that there are always the resources to provide free bed nets for everybody. Certainly it was not the case in our study areas. These were areas which were clearly underserved by the government of Orissa, and they still remain now after our study underserved. Something else which has been pointed out by economists is the fact that some level of co-payment may also serve the purpose of improving targeting. If you give nets to everybody for free, you're also going to give nets for free to people that don't really need them, and that's a form of waste. Of course, on the other hand, if you have a co-payment, you may screen out people that really need the nets a lot because they're poor. But the punchline here is that things are somewhat complicated. A third reason, which has been recently studied in at least a couple of papers, Kwan and Dupa and Ashraf et al., the ones that I cited above, is the fact that it's very common among practitioners in the field to hear the argument that if you give free stuff to people, they are going to waste it and they are not going to use it. So these are two studies that took that kind of argument very seriously, and they actually don't find any evidence of that. At least in those samples, they find that usage does not really depend on the price paid to get either the net or the water disinfectant, depending on which paper you look at. And these are two papers that use a very neat identification strategy. I'm not going to tell you what it is, but they are not simply comparing usage across people that have paid and people that haven't. So that would be very simple-minded and wrong. But they actually have a clever randomization strategy that allows them to actually nail down the causal impact, and they don't find any evidence that this is actually true. So what we wanted to do finally was look at a third alternative, which was instead of asking immediately for a cash payment or giving stuff for free, we wanted to see what would happen if we allowed people to repay over a 1-year period of time. So we are looking, we can say that we are looking at a third way. So the question is, can microloans offer a viable alternative? And in particular, when I talk about microloans, what I mean is that we offer people the choice of buying one or more of these nets, and they get the net, and they are supposed to repay over a period of time. So there is no money that goes from us to them. It's not that we give them money and then they can buy a net. It's really essentially what we can call consumer loans, right? So we give them the good, and they are supposed to repay over time. Okay. So where did we do this? The study in Orissa. This is where Orissa is within India, and those are the 5 districts where we operated. So we were working in a very broad geographical area. The districts are Kandhamal, Balangir, Bargar, Sambalpur, and Keonjhar. Orissa is, in India, the one state where the burden of malaria is highest. So that's why we did it there. Orissa has about 5% of the Indian population, but according to official statistics, quite recent, 2007, we find that 25% of malaria cases, 40% of falciparum cases, and about 30% of deaths. And by the way, these numbers here, 317K and 365K.
Alessandro, 40% is 40% of malaria
of the total in India. Yes. Yes. So it's 40% of falciparum in India. And those numbers are certainly a vast understatement, because the official records typically come from active or passive surveillance sites, but especially in rural areas, and Orissa is overwhelmingly rural. It's impossible not to think that there are countless cases where people simply have malaria, but they are never recorded. So those are really the official ones. So to tell you in a nutshell what we did, I'm going to tell you more later, but what we did is we teamed up with a microlender called BISWA, Bharat Integrated Social Welfare Agency, and starting from a list of villages where they were operating, we selected 141 villages, and we interviewed about 1,800 households in those villages. And we split the sample in 3 parts using in a random way, using one of these pseudo-random number generators. So we have 3 groups, each with 47 villages each. Control areas where we didn't do any distribution of nets. We have the microfinance group of villages where what we did is selling these nets through these contracts that I'm going to tell you more later with a 1-year repayment. And I should also point out that we sold these nets at full cost. So the cost even included the transportation cost. So there was no subsidization whatsoever. Yes?
Could you explain why you chose to randomize at the level of the village and not the household?
Because for two reasons. So first of all, we were aware of two possible issues. One is that there was all this literature that argues that there are externalities. So it would have been difficult to distinguish. It would have been more difficult to distinguish health outcomes between people that got the nets and others that didn't, because of the externality effects. And also, actually, I should say three reasons. The second reason is simply that it would have been difficult to give nets for free to some people and not to others within the same community, just from a logistical point of view. The third reason, and I actually think this is the most convincing one, is the fact that if you think about rolling out something like this, so expanding a program like this, the way you would probably do is you would expand this kind of service at the village level. You wouldn't address only a few people within the village. So this also tells you that because we did the randomization at the village level, all our results, at least up to this point, all the results in this paper are going to be what we economists call intent to treat, ITT. So we are going to compare outcomes among households in a certain kind of village with outcomes for households in a separate experimental arm, but we're not going to look at household versus household comparisons within village. Okay? Yeah?
I don't know whether you're going to talk about this later, but can you tell us a bit about any type of education or programs, educational program that the state of Orissa, has been sort of, they say, implementing prior, during?
There was nothing that I'm aware of, but this is a lame answer though, because we didn't collect systematic information about what kind of information campaign was going on. Something I can tell you is that the vast majority of respondents were very aware of the problem. And when the people were making mistakes in terms of what causes malaria, there were errors of inclusion. So somebody would tell you that contaminated water can lead to malaria, but the vast majority of people knew that mosquitoes can transmit malaria. Of course, given that we had both the baseline and the follow-up survey, we can check whether there was any systematic differences across area in terms of how much people knew. But unless I'm missing it, we didn't collect information about what kind of information campaigns had been done in the previous years, though. Something I can, well, let me actually, I would like to add something, but let me just postpone for a second for that.
Was there any interaction between the villages for the same reason?
All right, so let me get back to that in a sec. So, two groups and third group. In the third group, what we did is we gave away nets for free. And this we did because given that this kind of intervention is what most people seem to think that it's the right thing to do, we really wanted to add that benchmark because we thought it was very important. Yes?
Was it just one net per household? Or?
No. I'll get back to that. So something to keep in mind here when you interpret our results is that although we think our results are interesting and internally consistent, our study population was clearly selected. So we were not working with a random sample of people from rural Orissa. There are 2 degrees of selection. So first of all, we were operating in villages where BISWA, the microlender, already had a presence. And also we were operating with micro-lenders within villages. And this second thing actually is going to be very important for our results, we think, because this means that in places where, for instance, we gave nets for free, we didn't give nets for free to everybody in the village, but only to people that were micro-lenders, which is something that we had to do because because the potential buyers of the nets were micro-lenders here, so we couldn't change the population in this group. Okay, but this is going to be very important later on. So before I start filling all the gaps, before I start telling you about the details, let me give you the preview of the results. So first of all, the first question we wanted to address was, so can we actually succeed in inducing a decently large number of people to buy nets despite the relatively high price? And the answer to that was overall yes. So in our in sample households in our microfinance villages, more than half of them actually bought at least one net, and most of them actually bought, and many of them actually bought more than one. When you look at the number of ITNs delivered, though, and usage rates, what you see is that although there is this half-full glass, there is also the half-empty glass, because the microfinance, perhaps not surprisingly, certainly didn't reach the level of coverage that we did achieve instead with free distribution. And let me actually say this right now. So the free distribution was done based on how many people were there in your households and their age. So we had an algorithm according to that would determine how many nets you would receive, depending on the demographic structure, with a maximum of 4, because we didn't want to run out of nets too quickly. But overall, the number of nets given away for free was close to be large enough to provide potentially complete coverage for those households. Yes.
Do you know if households gave away the nets to their friends or neighbors?
I'm not going to talk about this here, but we have plenty of information about that. Yes.
Okay. They use it for fishing?
Not that we are aware of, not in this area. But not all nets that we gave them were still with the household at the end. Although the vast majority, I mean, the large majority were still there.
Okay.
So when we compare free and microfinance, what we see is that in terms of ITNs per head, there is about 0.52. There's about 0.5 in places where we gave them for free, but about half that in places where people instead decided whether they want to buy or not. When you look at usage rates, these are all self-reported. So this is self-reported usage the night before the interview. We find 16% of people were reported as having used an ITN the night before in microfinance villages, but 47% in free areas. And when we ask the questions about regular usage during the peak mosquito season, so a bit of a shadier measure, certainly with more measurement error, but still the gradient is the same. So 77% with free, these are actually reverted. So 70% for free versus 36% for microfinance, and very, very few in control areas. Okay. So the other thing we really wanted to do was to evaluate the impact of health, because just 1 second, because actually no, tell me now.
So when you say per capita, is that out of all of the micro slender people, or is that out of the population?
No, this one is 0.2, means that on average every household had 1/2 ITN per person.
Every household in the village, or in your
every household in our sample, and all of them were all microfinance clients. So it's not everybody in the village, it's our sample. All these numbers are for the sample. So, of course, we don't really care about Bednet usage. That's not, whether we sleep under net or not is not a welfare outcome or a health outcome. So something that we really wanted to have in this study was biomarkers. So we have objective measures of health. In particular, we measured malaria prevalence, and we measured hemoglobin levels with blood tests. So when I talk about anemia, what I refer to is hemoglobin levels below 11 grams per deciliters. Results don't change much if you change the threshold. But anyway, there are 3 outcomes: malaria prevalence, hemoglobin levels, anemia. When we look at malaria was determined using finger prick blood tests. These are rapid diagnostic kits, or RDTs, that you can use in the field, and in 15 minutes they give you the result. Something to keep in mind is that these things are going to give you a binary answer. You have it or you don't have it. Ideally, you would also like to verify whichever result you have with microscopy, and microscopy would also give you an estimate of the level of parasitemia in your blood. We don't have that. So this is a 0-1.
So that means that, does that suggest recently infection or history of?
Yes, no, it's recent. So the kind of RTT we used is very good at detecting current infection. It can also detect recent infections, but it's extremely difficult for it to detect an infection that's more than 2 weeks ago, 2 weeks older. But this really is at one point in time. And yeah, right. So when it comes to these outcomes, what we find is very disappointing results. So when we look at malaria prevalence, there is no statistically significant difference across groups. And actually, if you look at the point estimates, they even are of the wrong sign. So we have actually higher prevalence in microfinance and free villages. Although again, the differences are not large enough that you can reject the null of equality, but certainly no benefit. When you look at hemoglobin levels or anemia, they are completely flat across the three arms. They are pretty much identical. 11.4 mean level of hemoglobin and 38% anemia across all the groups. Of course, we were very disappointed and quite puzzled when we saw this, but it turns out that we think that these results actually have something very important to say to the public health literature, and I'm going to get to that later on, okay? So another couple of things. So these ones I'm gonna talk about now, but just 1 second. Well, actually, let me.
For the potential, when you guys were looking at benefits, what sort of timeline was given between when the Bednets were issued and?
This was between. I'm going to tell you more later, but this was about between 1 year and 1.5 years. So you certainly, within this time frame, you certainly would expect to see benefits if what you are doing makes sense. So if you look at the totality of these papers reviewed by Langler in 2004, as far as I remember, all of them were done, well, almost all of them were done with the 12-18 months framework. So there's nothing special about that in our study, I would say.
Were they retreated? You said that retreated at 6 months?
In free areas, yes. In microfinance areas, only if, I'm going to tell you that in a second, but fewer of them were. I'm going to tell you in a second why. So, Bednet ownership and usage, health, what else did we look at? So something else we were interested in was the fact that we know that there are several technologies out there that will protect your health only if you comply with a certain kind of behavior over time. So for instance, with deworming drugs, if you take deworming drugs for a couple of months and then you stop, you're going to get, if there are worms in your environment, you're going to get worms again quite quickly. So you really need to keep taking the drugs. With ITNs, unless you have one of these long-lasting nets, you need to retreat them with the appropriate chemical at the appropriate concentration periodically. Otherwise, the protective power of the chemical is going to be gone. So in this kind of situation, what we wanted to see was whether we could increase compliance with the appropriate behavior, which in our case was retreatment, with a certain kind of contract. And so what we did was the following. So in places where nets were sold, so in the microfinance villages, we sold 2 different kind of contracts. Either you would buy the treated net, and we would tell you, we are going to come back in 6 months and in 12 months, and we're going to retreat the net. But if you want to have the net retreated, you have to come up with the cash. And among these guys, it actually turns out that a number of people didn't retreat. If you decide instead to buy the second kind of contract, you would buy not only the treated net, but also a sequence of 2 retreatment. So essentially, you can take the second contract as a contract which commits you to retreat at least twice, because if you buy that contract, you start repaying that kind of bundle immediately. So there is no extra cost for you when we come back to retreat. And the retreatment rates, it turns out, were very, very high in this case. Now, of course, people choose which contract want. So you cannot simply compare retreatment rates across contracts, which is what we do here. So what we see here is that when you compare the retreatment rates between C2 and C1, so C2 is the commitment contract, C1 is the other one. In the first retreatment, 84% of the nets were retreated versus only 36 for people that didn't commit. Second retreatment, the retreatment for both went down, but still we have 74 and 21. Now, you can imagine, for instance, that if you think that you couldn't care less about the retreatment, you are certainly not going to commit to buy. And so I cannot simply take these numbers and say that, well, it is the commitment contract that caused these differences. At the same time, so these results are non-experimental. We actually wanted to do them experimentally, but we just, honestly, we didn't have enough funding to have separate treatment groups. So what we did, the best we could do at this point was to simply look at whether these differences survive even after controlling for a long number of household characteristics, which did help in predicting which kind of contract you chose. It turns out that these differences remain almost identical after you control for all these other things. But being an economist, I tend not to believe results where you simply control for a lot of things. So these are, I think, are results which are very interesting, but to be taken with a grain of salt. Okay. Fourth question, the fourth issue was we wanted to revisit this issue of whether usage increases when you pay for the product. And it turns out that our design was not ideal to study this kind of question. We didn't have the kind of RCT that Quen and Dupas and others had. But it turns out that in our case, we actually find that nets that were given away for free were being used more, and statistically significantly so, rather than the nets that had been purchased, which essentially, despite the fact that the design is not ideal, still allows us to reject the null that the reverse is true. So our results from this point of view are really consistent with this other literature coming from economists that suggests that the point that the free stuff is not used at all may have been overstated. Though, of course, this is what we find in a certain time, at a certain time, in a certain place, and so on and so forth. 3 and 4 I'm going to abandon now, so I'm gonna start talking about the details of the RCT, but these are in the paper anyway.
In the C2 group, were there not enough numbers to compare those to controls to see if there was a difference?
That's a good question, and we have not looked at that yet. So I actually don't know if
that would be your highest incidence of appropriate treatment versus control.
Yeah, no, I agree. I think I think you're right. So I think we can do more with the difference between the C1 and C2. Yeah, that's a good point. So where we started from? We started from a number of villages, a number of villages where BISWA operated in these five districts, and these villages are, to go back to something that Giovanna, you were asking before. These are villages where no distribution of ITNs was expected, so we didn't expect any particular intervention to go on during the study period. In the paper, we actually talk about the fact that it does look like nothing happened. So our results are not due to something else being done by the government at the same time. We have district stratified selection, and to answer the question you asked before, so how much connections there is between these villages. So we took care of, in India, villages are usually organized in panchayats, and a panchayat is, they often have between 3, 4, 7 villages. So we took care of never including more than one village per panchayat, really to try to minimize the level of interaction. So the randomization was essentially done at the panchayat first, and then within panchayat we would select one village, and so we never had one treat and one control within a relatively small area. And also the geographical area, as you saw, was quite spread out. So sample selection based on lists that BISWA gave us, and with randomization. At baseline, we tested all pregnant women. There weren't so many of them. All children under 5, their mothers, plus one randomly selected adult, where adult means 15 to 60. The baseline survey was done in May, June of 7, when we also measured malaria and hemoglobin. Yes?
In each village, what proportion of households were BISWA households?
All right, good question. And this is actually terribly crucial for our interpretation. It varies, but it's on average it was somewhere around 20%, but it does range between close to 0 actually in a few large villages and 25. There are a few outliers with 35% or more, but very, very few.
And are they the follow-up question obviously is that are they very different from the non-BISWA?
That's a good question, and actually it turns out that along some dimensions they are, but along most dimensions they are not. We don't have any of this in this paper because we focus on our on the sample itself. But we're actually working on a separate paper where we will look also at people that were not part of our baseline sample, and we are going to have information also for non-BSWA households. But in terms, in particular, of net ownership, it doesn't look like they are particularly different if you look at the control areas where we didn't do anything. But there's more than that, of course.
Do I understand all your outcomes are in pregnant women?
No.
Can you go back one
No,
slide?
pregnant women are...
Not pregnant women, but women.
So, baseline...
Under five, okay.
You're right. And also there are men, because we also selected randomly one adult that could be a man.
And your results are uniform across all, that you showed us earlier, are uniform across all age groups?
Actually, they are not, but the differences are mostly, the differences we find are mostly across groups and not across groups interacted with treatment. So what I mean is that the differences across treatments are quite similar overall across different groups. So we don't find that everything is driven by certain demographic groups.
What is the Bednet literature on the ITP literature on? Is age a factor in how much they work or don't work? Look at the literature, because obviously malaria is much more common in kids. So do you have
well, the thing though is that symptomatic malaria is. I wouldn't say that malaria per se is more common among kids.
Symptomatic.
Right, yes. So most of the studies I know of, I mean not all of them, but many of them certainly were looking only at either pregnant women and or children under
that's
5.
where the rates are
So
highest,
yeah,
of
exactly.
symptomatic
And
malaria.
that's also because those are the most at risk categories.
Right.
So in terms of differential impacts across ages, right now I actually don't remember anything. Any sort of common wisdom about that.
Yeah, because what you hear when you go to the field is that kids never sleep under bed nets.
Right.
So you really can't evaluate bed nets by kids. You only can look at adults. That's
It's actually
I mean, that's what they say
It's
in the
mostly.
field.
I think it's mostly the teenagers that are problematic somehow. So the very young kids.
Yeah, young kids
do
stay with
sleep,
their
right.
kids, right.
Exactly. No, really. And that's actually what we find too. So I'm not going to have time today, but in the paper we do see that the ones that are most likely to sleep under the net are actually very young, between 1 and 3, and then there's a dip when they become teenagers, and then it goes up
But
again.
you analyze your data, and those that slept most under the net, you still had no difference.
Yes. So what we look at is different demographic groups, and we still can't reject the now of no difference. We don't have in the paper results stratified by net usage, because net usage is endogenous. So we didn't want to do that because you choose whether to.
You may only want to use nets in
Well, that's what I was trying to get at,
children,
what-
because if you use it in adults and they work, if you run out of a net, you're suddenly sick.
No, I can tell you that at least based on our data, net usage was quite homogeneous across different groups. This I know, but I didn't link usage. In this paper right now, we didn't link usage within experimental arms to health outcomes because usage is itself endogenous. So we only wanted to do the ITT comparisons.
So these are households that have multiple generations, or they're mostly nuclear families?
It's common to have multiple generations. They're not terribly large, and they're not as large as some that you can find in Africa, for instance. So average household size was 5.5, which tells you that in most cases, the model household has husband, wife, and 3 kids.
38 is pretty high.
Yeah, right. Although you do find you do find elderly in some cases, but not super frequent. And that was the baseline. Then intervention was done with the net sale or the net delivery was done in October, November of 5. There was a brief information campaign done everywhere. Yes?
Given that BSWA at the end of the day is a microfinance agency, and their clients are people who sought loans, should we be worried about something about their risk aversion, that they're systematically more risk averse, and therefore?
This is something we can check, so I haven't looked at that, but we certainly can check that because of what I said before about our having data at follow-up also from people that are non-BSWA households.
Okay.
So in principle, we could look at that. I would not expect them to be exactly identical. So in terms of external validity, I mean, that's one of the things that I said in the beginning. I mean, that's something to be taken into account.
But that would have implications for the way you think of your results as well, because if these are really risk-averse people, then their utilization rates across different arms might not look...
So, the thing though is that risk aversion by itself may also be correlated with many other things. I mean, it's possible that people that have, suppose that people that have access to microfinance are overall better off. You may actually find that they are not more risk, even if maybe their theta parameter is higher, so they are risk averse conditional on consumption. If their consumption is higher, they may actually end up being less risk averse. So it's a bit of a difficult business, but we can certainly look at that using the follow-up data. And we also have information on time preferences, on perceptions about malaria, so there is plenty that we can do. That's a good point. The price of the nets, so like I told you, these were not outrageously expensive, but also not so cheap. So the cheapest net was a single net where we purchase only the net and nothing else. 173 rupees, this is something like $3 and something like that. The daily wage in the area back then was about 50 rupees per day, so it's not a small amount of money, especially if you want to buy 2 or 3. 1 kilo of rice, 10 rupees. The median per capita expenditure per month was 600 rupees. Okay. First and second retreatment and follow-up. And by the way, I should say at the follow-up, given that we had significantly more funding, we actually included everybody in our target population. So we tried to test everybody. We couldn't succeed in testing everybody, but we have about 75% of people in these households actually was tested by us. So the gender and the age distribution is much more balanced. Essentially, all the results that we have in the paper look at two different kind of estimates. In one estimate, we look at changes for people that were both at baseline and at follow-up, and in the other set of estimates, we look at everybody, regardless of whether they were at baseline. We also do this second thing because we have much more information at follow-up than at baseline. And after all, the baseline is only really necessary because it gives you more power when you do testing. It allows you to check randomization. But if the randomization worked well, and if attrition is non-differential across different areas, in principle, you can do an RCT with only a follow-up. So we also do that. And in the paper, we show that there is no evidence of systematic differences in attrition, meaning losing households differentially between one group and the other, or also in terms of the probability of entering households or exiting the households, conditional on having households at both baseline and follow-up. So we don't see anything particularly striking there. Summary statistics. These show you that overall the health outcomes were quite balanced across groups. So these are means for control, means for free, means for microfinance. The p-value is for the test of equality across the three. There are two of them where we reject. One is expenditure per head, although the point estimates are actually quite similar, but these are precisely estimated. One which was unfortunate was this one, because we see that there were more ITNs per head in places where we gave them away for free and where we sold them. But anyway, the results are going to be diff and diff, so we are going to take care of baseline differences. Something that needs to be pointed out here is the fact that this is not a place where nets were unheard of. A lot of people were already using them. So if you look at nets per capita, proportion of people that use nets or that say that you use regularly nets. At the same time, what you see is that using treated nets was instead very uncommon. So this is where we thought we really could make a difference. But overall, there is good balance, and there are many other variables that you could look at, and there is overall good balance. So these are the results, and here I'm somewhat going to go quickly, both because I'm short of time and also because I already gave you all the punchline when I showed you in the slide before. But there is essentially two kind of regressions. One where we look only at follow-up. Okay, so this is the outcome measure for somebody at follow-up. So the intercept will measure the mean outcome in control areas, and this parameter is going to measure the difference between microfinance, between free and control. This coefficient is going to measure the difference between microfinance and control. And also we have some estimates where we look at changes, so the difference between post and pre-intervention. In this case, this parameter measures the change for controls, and this are going to be the additional change in microfinance and free. All standard errors are adjusted for correlation within cluster, of course, because that's the way we did the randomization. These results simply really confirm what I told you before, so I don't think we really need to look too much at them. This simply tell you that in terms of take-up, these were measured at the time of the intervention, uptake of nets was much higher in places where we gave away the nets for free, not surprisingly. These are ownership rates, and very little increase in control areas, more than twice as much in microfinance areas, but this number here is actually much larger than that. So increase in ownership of any nets when we calculate the changes, 0.07 nets per person, but 0.18 in microfinance and 0.35 in free. Okay, so large differences. And all these coefficients are significant at the 1% level, as you can see. Measures of usage are consistent with the ones that with all the estimates on ownership. Let me actually just show you a couple of things that are interesting here. So here, what we look at, so this regression is at the individual level. So for everybody, we asked whether this person slept under net and whether the net was treated or not. In the control areas, we find a small increase in the fraction of people that slept under net. What's interesting is that in microfinance and especially in free areas, and these are, untreated nets, so what we have here is that there was actually a decline in the fraction of people that were sleeping under an untreated net, which we think is interesting because it suggests that these guys were really replacing the old untreated nets with the new, better nets that we gave them. Something else I want to point out is this one. So when we did a complete census of sleeping spaces, and for every space we asked, so who slept there? Was there a net to protect that space? Was the net treated or not? Every time a net was mentioned, and we did the same also for nets that were not in use at the time of the interview, the surveyor asked to actually see the net. We wanted to make sure they were not all hanging in the pond of fishing frauds, right? And in vast majority of cases, in 85% of cases, the net was actually observed. You can also see that in free and microfinance areas, the probability of actually observing the net was even higher. So here, certainly, we don't see any evidence that in free areas people were really hiding the nets because they were ashamed of the fact that they went fishing. And this also gives us some more confidence about our estimates in terms of usage the night before. These are BISWA nets only. Our nets were clearly distinguishable from the others. They were marked. So pretty much none in control areas, also a sign of the fact that there was no contamination. Higher, significantly so in microfinance areas, much, much higher in places where we gave them away for free. These are instead the sad results. So here we're looking at the health outcomes. So these estimates here always have way more. The sample is always way larger because, like I told you, at follow-up we try to test everybody. Instead, these ones are the differences. So here we can only include somebody that was tested both at the baseline and at the follow-up. Mike, do you have a question? No. Okay. So these are the figures I showed you before. So higher, actually, prevalence in intervention areas, although not significantly so. When we calculate the diff in diffs, the point estimates become even higher, but again, not significant. When we look at anemia, these are pretty flat, and these coefficients are extremely small. Here again, this is the only number that gave us some good news. So here we find we cannot reject at the 5% level that at least for the guys that were measured both at the baseline and at follow-up, hemoglobin level went up. I should say, though, that this one is a very small number. This one is something like 15-20% with standard deviation at baseline, so not a big deal. Yes?
Is the malaria prevalence in this group very different from the rest of the state that you showed us right at the beginning?
The rest of the state, you mean the rest of Orissa?
Yeah, you're in the right at the very beginning. You
so I wouldn't want to make that comparison because those numbers come from official figures, okay. And so honestly, I didn't do a calculation, but those don't come from a random sample of people from Orissa. So I don't know. Right. Okay. So why? And there are many different things that we look at, and a number of things we can exclude. So one thing that we look at is, do we find that there are some sort of perverse behavior? So people maybe now sleep under net, but they completely stop taking different precautions. Mm-hmm. And I don't have time to go through the details, but we don't find any evidence of that. There is some differences in rates of indoor residual spraying, but they don't explain anything of the results. Something else that we were worried about is that for some crazy reasons, maybe people that had malaria were systematically more likely to be in our sample to accept to be tested in microfinance or free villages, but the differences in missing blood tests are very small, not significant, so nothing seems to be there. Are we exaggerating net usage? Well, we didn't check really night after night, so this is hard to tell, but at least in terms of the accuracy of the estimates about usage the night before, we think those are actually quite accurate, because because usage the night before was measured in 2 different sections of the questionnaire independently, and it's hard to believe that somebody could have lied to us in such a systematic way in 2 different places of the questionnaire. Of course, this doesn't mean that there was an exaggeration in regular usage during the year, so that we cannot exclude.
And the interviews were conducted, how long did it take?
Interviews there was variation, but usually between 2 and 4 hours, so they were relatively long.
But they were concentrated
Within a village.
so one day, within a village in one day?
Usually, yes. We saw in several cases, in many cases, they had to go back, but usually, I would say that the mode was that one household would be interviewed one day in most cases.
So you don't think there was any sort of social desirability bias with respect to,
So, I don't think so, but it's one of those things that we cannot absolutely exclude, though. It's possible that there were errors in the way we recorded malaria and hemoglobin levels, but it's not likely because we had biomarkers. So this doesn't seem to be an important concern. We devote a good deal of space in the paper anyway. So here we go to what we think is actually the most likely explanation. And talking to several people that write in the public health literature, it sounds like this really may be it. And this is actually, here I go back to the question you were asking before. So, so what is the fraction of people that are BIS1 members? So this is not exactly that, but what these numbers have is on the horizontal axis, you have the number of program ITNs, so our ITNs, divided by total village population from the census. And on the vertical axis, you have here the change in malaria prevalence between baseline and follow-up, change in malaria prevalence. This is free, this is microfinance, and this one instead is malaria prevalence, malaria prevalence. So every dot is one village. And these lines represent simple OLS regressions. There are 2 of them because the ones with the crosses excluded the very few outliers where coverage was high. But overall, we don't find, the first thing we wanted to see was whether we found any evidence that in places where there were more nets per inhabitant, we actually found better results, and we don't have any evidence of that. Now, the problem is that when you actually look at the literature on ITNs that's out there, pretty much everything that we know in terms of cluster randomized controlled trials is here. So all those studies have coverage rates in the range of 60, 70, 80%. So these results really do not support the story I'm telling you now, which is there were not enough nets to really break the malaria cycle. But they don't even contradict those earlier results, because those earlier results were about something which is really out of sample for us. And it turns out that if you look at more carefully at this survey in 2004 by Langler, there are 22 RCTs that survive his selection criteria. 14 of them are cluster randomized controlled trials like ours, and again, all of them have very high coverage rates. There is one of them which was done in 5 strata, and guess what? The one stratum where they say that usage rates were low is the one stratum where things didn't work out. There are also 8 RCTs where instead coverage was much lower because the randomization was done within community. But again, our study is not really comparable because these are studies where there was a lot of investment in really testing people frequently, in informing people, in trying to convince people with ongoing interventions that you have to use nets, and also the fact these were studies where they did the randomization within the community, but in almost all cases there were very, very few communities. So there is pretty much no study like ours which is a randomized controlled trials with low coverage within community. Our study is really very, very different. And this is actually a quotation from the same Langler paper that really tells you that what I'm telling you now is not something that we made up. It is plausible, although with our data, unfortunately, we cannot really nail it down conclusively. But what it says is that the results presented in this review are from randomized controlled trials where the intervention was deployed under highly controlled conditions leading to high coverage and use rates. Therefore, the bulk of data of this review describe blah, 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 blah. But anyway, what they say is while the difference between efficacy and effectiveness, so what you can have in a tightly controlled RCT and what you can have in real life, may be small for certain interventions such as vaccination and surgery, it can potentially be large for preventive interventions. And this is just a summary of what I've been telling you so far, but let me just give you another quote from Hawley et al. This is actually one of the most beautiful RCTs that have been produced by the literature surveying Langler. This is the Kenny RCT. That was an amazing study, and one of the conclusions that he comes up with is low levels of coverage with treated nets, or worse, untreated or poorly treated nets, may do little but fritter away scarce resources. So this is really an important point for us because unfortunately sometimes economists have this tendency of, oh my God, I found a result that nobody else did find, so everybody else is wrong and I'm right. But we actually think that where the importance of this work lies is not in contradicting studies which have been done extremely well, in my opinion, but rather in complementing them with the kind of situation that had not been analyzed before. So our punchline really is not, well, ITNs are nonsense, they don't serve any purpose, but really our punchline is that you really need more. I mean, if you want to go with ITNs, you should make sure that you don't protect only 20% of the population, but you should really go wide because externalities are likely to be very, very important. And probably you should also go beyond that. I mean, with land management, water management, and interventions of different sort, active, passive surveillance, and so on and so forth. And well, I really didn't talk too much about this, but something else also that comes from our study is the fact that in situations where budget constraints are terribly binding, microloans may offer some possibilities, although you have to take care of, to really consider the fact that if microloans means that not enough people are still unable to buy, you may end up with disappointing results. And the other result that comes out of what we did is the fact that in situations where you want to impose a cost and there are costs on compliance, you may be better off imposing that particular cost up front because this way compliance is going to be better. And I'm sorry, I went a little bit over time. That's all.
Thank you.
I just had one question. Were you surprised?
Yes.
In retrospect,
yes.
Might this have been maybe obvious, in the design of the trial? I'm just wondering how surprised you were.
So, I think that the obvious part was the fact that we ended up with fewer nets in places where we sold them at full cost, relative to places where we gave them for free. Also, despite the fact that in places where we were giving away nets for free, we were not pouring bed nets over people. We were trying to be a little bit, conservative, so we didn't end up with 15 bed nets per household. So, from that point of view, the order of the fact that one was larger than the other in terms of uptake was obvious. It was not obvious to what extent it would have been lower, and this I thought what we find, I think, is an interesting result. Also because it does contrast a lot with the results that others have found in different contexts, where even very small copayment really led to a huge decline in demand. So that, I think, is still valuable. But was I surprised that some people don't buy? No, that's
no, I mean more that you did reduce the burden.
So that I was very surprised. Yes, and one of the people in our research team is a doctor, and so he was the one that also helped us out coming up with it. And what I think it's a correct assessment that what we all expected was that we would see some decline in malaria in places where we gave away the nets for free, And we would find some decline, but not so much, in places where we were selling the nets simply because we sold more of them.
Even though the coverage was only, whatever it was, 20%.
Yeah, exactly. Because, and the reason why we did not, we certainly, just 1 second, but the reason why we did not expect to find no impact was the fact that reading the literature, there seemed to be a fair consensus about the fact that these nets were very effective. So we did expect to find those impacts. I mean, if we expected these outcomes, I can assure you that we would have designed things differently. I mean, certainly we would have included a number of villages where everybody, BISWA or non-BISWA, would have gotten nets for free to ensure the kind of coverage that you would find somewhere else. And in the paper, we actually do cite a few papers that have been done not in our study areas, but in neighboring areas in Orissa, where ITNs have been effective. But unfortunately, those are studies where the whole thing was done with a before and after with maybe 2-3 villages. So it's hard to extrapolate. But we were very surprised.